maybe we can have some questions at the end towards that. There's so much to learn about ECPR, but I want to present a dear colleague, Dr. Gustafsson from Copenhagen University Hospital. He's a professor there and a leading figure in the whole region in heart failure. And Finn is going to talk about reperfusion injury and AMI shock, role of percutaneous MCS devices.
Thank you very much, Eduardo. And I really want to start by thanking the organizers for inviting me. It's wonderful to be back at this meeting. It's wonderful to be back in the U.S. and meeting everybody. So I just want to say that when Marwan before showed the slide with the response time to the invitation, I was dragging down the average there for sure. So thank you so much. So, and I'm happy to be here even if the topic I've been given is a little bit tricky, reperfusion injury and AMI shock. So that's really going a little bit away from shock, and this is more preventive cardiology for this kind of meeting, because this is really acute myocardial infarction more than shock. These are my disclosures. I think we were all brought up with the knowledge that there is a clear relationship between the size of an infarct and the prognosis after myocardial infarction. And this even holds true now in current times. These are fairly recent data from 10 randomized clinical trials where cardiac MRI was done after the infarct. And you can see that there is a clear correlation both with all-cause mortality and heart failure hospitalization with the size of the infarction. So that holds true even in the primary PCI era. I think the most impressive thing about this graph is, and I think that sets the stage for the talk, is that in those patients where you keep the infarct size less than, say, 10%, there is really no mortality and very little morbidity. So this clearly is important. And that, of course, goes back to our medical school knowledge about time is muscle. And it's simple, we just need to reperfuse very early and everything is good. So the patient has an arterial myocardial infarction, short door to balloon time, and open the artery, and the ejection fraction is good. But we all know that the exact same patient with the exact same ECG and the location of the coronary occlusion treated in the same manner can end up with a very different heart after the procedure. And this led to the understanding of that there is more than ischemic time, but to the size of the final infarct, and that led to the understanding of the reperfusion injury part of the infarct. So basically, we're looking at the patient with onset of chest pain, and until the time of primary PCI, there is an infarction due to simply the ischemic injury, and then there is an added injury, and adds to the infarct size, which is due to the reperfusion injury. And that is what I'm trying to address, the role of mechanical circulatory support. The pathophysiology behind reperfusion injury is really complex, and there was this recent review in Nature Reperfusion that's really nice. And of course, there is an understanding that cardiomyocyte death due to necrosis and particularly apoptosis is important in this process. There are also other apoptoses I'm not even going to try to pronounce, but with the part that I do understand is that the cell death obviously is of importance and is driven by molecules that we will discuss later. There's also one more very important part of the reperfusion injury which relates to the microcirculation, both with changes inside the vessels, such as microvascular stasis and hemorrhage, and also external forces such as tissue edema, which will compress the capillaries and induce microvascular dysfunction. So these we need to keep in mind when we discuss the treatment of reperfusion injury. So there have been over time several pharmacological and physical attempts to reduce reperfusion injury, such as multiple drugs, and attempts such as inflating and deflating the blood pressure balloon in the ambulance on the way to the primary PCI. And I think it's fair to say that so far these studies have yielded inconsistent results. And that has led to the proposal that mechanical circulatory support might be an efficient way to reduce the reperfusion injury, because we know that mechanical circulatory support in the setting of acute myocardial infarction may increase the collateral coronary perfusion pressure. It certainly, if it unloads well, it decreases the left ventricular and diastolic pressure and decreases the wall stress, which in turn, of course, decreases the myocardial oxygen consumption. And we know that that's directly related to the size of the infarct. So this makes sense. So the question is, can mechanical circulatory support in acute myocardial infarction reduce reperfusion injury and infarct size? And if it can, how does it do it, and how should the reperfusion be timed with respect to the onset of unloading? So we'll start with some animal studies trying to address this. And the first one that really, I think, did this in a way that was very clear was this study from Belgium, from Bart Mayen's group, looking at 26 sheep, which were treated with an Impella CP or control, so an occluded LAD, looking at the oxygen consumption here on the left. And you can see that the animals that were treated with full support clearly had a lower myocardial oxygen extraction than those animals that were treated with just control and reperfusion after 60 minutes of ischemia. And you can see on the right, where the white bars are, is the infarct area at risk, and the area at risk, and the black bars is the infarct area as a proportion of the area at risk. And you can see that in the group that received support already from the onset of ischemia, which obviously is not clinically relevant, but this group did extremely well with small infarction. But the group also that got support during reperfusion only, which is more clinically relevant, also had a decrease in the infarct size. More recently, Naveen Kapoor and his group looked at different protocols to induce reperfusion and mechanical circulatory support in a pig model where the infarct was induced by 90 minutes of LAD occlusion with a balloon. And the groups were a reperfusion alone, a group that got an Impella CP for 15 minutes before reperfusion, a group that had the Impella turned on for 30 minutes before reperfusion, and a group that had immediate reperfusion and then subsequent circulatory support. And you can see on the right the percent infarct of the area at risk, that group 3, the one that had 30 minutes pump on and subsequent reperfusion, had the smallest infarction. And this study went further. It's actually a very elaborate and very comprehensive study, not just analyzing infarct size, but also a number of potential mechanisms, and focusing very much on also different molecules that may be pivotal in this process. One of them being stromal-derived factor 1 alpha, which is clearly reduced in the group that does not get mechanical circulatory support. And you can see that this group that was treated with unloading before reperfusion had a more normal level of SDF1 alpha. And finally, that the scar tissue formation was negatively associated with the plasma SDF1 alpha, indicating that SDF1 alpha might be a protective means that the heart secretes to reduce the reperfusion injury. And this was even shown in a model where the SDF1 alpha was blocked, showing that this attenuated the effect of reperfusion. So this really breaks with our understanding that time is muscle, because it indicated that delaying reperfusion by 30 minutes when there was circulatory unloading on board actually was associated with the best outcomes for the animals. This is somehow in discrepancy with this paper that came out from the Salt Lake City group just recently, also a pig model, quite similar with 60 minutes of ischemia, and looking at 3 groups: is the conventional ischemia with reperfusion, the upfront unloading with an Impella for 30 minutes before reperfusion, so very similar to the former study, and then a group where the unloading and reperfusion was done simultaneously after 60 minutes of ischemia. And you can see the infarct size on the right, showing that there was actually no difference between the control and the ischemia with delayed reperfusion, but that the group that had simultaneous reperfusion and unloading had the smallest infarct. So not really completely consistent with the former study. Now, obviously, there are differences between the studies, one being the ischemia duration, but clearly there is some need for a better understanding here. There is a number of animal studies that have been performed, and fortunately somebody undertook the task to combine them in a meta-analysis very recently, and you can see that if you look at the bottom, that overall there is an effect of mechanical circulatory support and unloading in the setting of acute myocardial infarction in animal models, leading to about a 2.2% absolute reduction in infarct size, so that's probably around a 10% relative reduction in infarct size. So that is the data that's out there. So if MCS works, which MCS should we use? Because we know that not all MCS is created equal. And this was actually nicely studied also by Naveen and his group. Here you can see a study with 120 minutes LAD occlusion in a pig model. Again, the continued occlusion, a group with Impella pre-reperfusion, and one with VA ECMO pre-reperfusion. And you can see that VA ECMO was associated with the largest infarct size, and that Impella was associated with a decreased infarct size compared to the continued occlusion. So nicely showing that there is difference between the different percutaneous MCS. And this was nicely associated with the change in LV stroke work, as you can see on the left, with the Impella clearly reducing the stroke work with no change in the VA ECMO. And I think the biggest contribution of this study was that the investigators tried to address the collateral coronary perfusion. So they measured the coronary collateral flow index, which is a pressure-derived index of collateral flow, in this case from the circumflex artery, and really focusing on the coronary wedge pressure, which you can see was positively influenced by unloading with the Impella with no change with VA ECMO, suggesting that collateral perfusion is of importance and may improve the microvascular environment, leading to smaller infarcts. But it's important, I think, to realize that model versus reality plays a big role here. Until recently, at least, most of us did not walk around with a pig heart in our chest, so we need to focus still on human hearts. And of course, in the models, we have a controlled 100% occlusion. There's no disease of other vessels. The time of occlusion is known. Whereas in patients, we often have partial reflow due to the heparin or whatever is going on in the ambulance. There is the presence of thrombus formation, and embolization can definitely play a role. And of course, concomitant coronary disease can go both ways, right? Because it can actually limit the collateral flow, but it could also induce preconditioning, which might be beneficial for the reperfusion injury. We never know the occlusion time, and I think in both groups, arrhythmia can play a big role. Certainly, my own experience with the pig model is that if you occlude the LAD a little bit too high, you spend the rest of the afternoon cardioversion and until the unmistakable smell of bacon is in the cath lab. So we need to look at a few clinical data to make up for that, and there are actually it's very limited. We have the CRISP-AMI randomized trial comparing PCI alone with aortic balloon plug plus PCI in 337 patients. They were not in cardiogenic shock, and the primary endpoint was infarct size. And you can see here that there was no difference between the two groups. In fact, a trend towards a larger infarct with the IABP, which was a disappointment, and also there was no difference in the clinical endpoint of death. So this was not, at least in this manner, with this setting, with this reperfusion strategy, successful. And then the DTU Stemi pilot trial was published, and it's not a trial of unloading versus no unloading, because all the patients, the 50 patients, all were unloaded with the CP, but it tested the hypothesis that delaying reperfusion by 30 minutes after starting the unloading was associated with, was feasible and did not increase infarct size. And that was shown in this study, which was recently published. As you can see, no difference in outcomes with this strategy, and this has led the way for the DTU Stemi trial, which is ongoing, testing whether unloading with an Impella and delaying reperfusion compared with conventional therapy will help. So this is a meeting about cardiogenic shock, and unfortunately we have very little information about patients who are already in cardiogenic shock with the effect of reperfusion. We've seen this slide already several times today, so no perceived effect of a balloon pump in this situation. We will get data from the Danish-German cardiogenic shock trial, which has been mentioned already. Obviously, it's not going to inform us about the effect on reperfusion, but we may be able to tease something out on secondary analysis of ejection fraction, et cetera, of patients who were treated. I spoke with Jacob Müller, the primary investigator, this morning, and he told me that patient number 277 was randomized in Leipzig today. So they are moving slowly, and it is possible to randomize patients in clinical trials. So my conclusions is that pCMS to reduce reperfusion injury is effective to reduce infarct size if applied early in animal studies. It is clear that effective unloading appears essential so that LVADs such as Impella is more efficient than ECMO and probably than balloon pumps. The optimal timing of reperfusion remains uncertain, and we will get more information about this from clinical trials. And we don't really know anything about the development of acute heart failure or cardiogenic shock. We could not show anything for the balloon pump, and we don't have any data for the Impella, or ECMO for that matter. In patients already cardiogenic shock, the effect of percutaneous MCS on reperfusion injury is unknown, but in these patients, of course, the MCS also serves other purposes, such as supplying the brain and the kidneys and everything else with blood flow, so it's going to be difficult to tease out in shock patients. But I think it's really important that in patients that are not in cardiogenic shock, we need dedicated, very thorough trials to understand if we can reduce reperfusion injury, because there needs to be a balance before we implant percutaneous MCS in all anterior STEMIs. I don't see that really as a feasible situation, but I may be proven wrong, and we'll see the interesting data from the DTU STEMI trial. So with that, I want to thank you for your attention.
Finn, first of all, thank you for taking all the journey from Copenhagen here. Dan, maybe we'll start with you because it's exciting. We always spoke that we need to open the culprit lesion first, and then I'm starting with the non-intervention first. We'll get to the intervention, and just because the study design and what are we expecting to see here?
Yeah, look, there. Actually, since we're in Houston, we should also credit Richard Smalling.
Yes.
Who did work in this earlier than Bart Maines, I think maybe in the early 90s. I don't remember the exact date, but he showed with the hemopump and also balloon pump that it reduced infarct size in animals. So there's been a very long history now, 30 years, of understanding that reperfusion, unloading during ischemia before reperfusion in animals can work. Can reduce infarct size. And the DTU, although it was overall a negative study, it was the pilot study was just a pilot study, really to show that door to balloon time is not delayed. You still have less than 90 minutes, and it was feasible. You could randomize patients. Physicians did not, get freaked out, and they were able to abide by the protocol. And there was a signal, in patients who had a larger infarct. That was indexed by the sub of the ST segment elevations across the precordial lead. So those patients did have a lower, those that got early unloading did have a smaller infarct size. So there's hope here that this could work. All the things are there to say that this is a rational and ethical study to do. We know that infarct size correlates, as you showed the study from Greg Stone, that the analysis that infarct size matters, and even if we can reduce it, by 20-30%, it should have an impact on heart failure, and maybe not necessarily on mortality, but heart failure.
So now Dan, we are going to take all the interventions that we have here on the panel. That, since I remember, told us you take the patient with ST elevation MI and you open the artery the fastest. What do you feel about it?
Well, You know, I mix, and I agree with the preclinical data. I think the difficulty is patient selection. And my worry about door download trial is that it's too healthy. So these are patients who are 1 to 5 hours, first infarcts, no cardiogenic shock, no cardiac arrest. We actually modeled that, and we have a registry called the Midwest Stemi Consortium. We had 7,000 people that fit that criteria. The in-hospital mortality was 1.2%. The 5-year mortality was 4.3%. It's so healthy of a patient population.
Yeah.
Now, I think there's been a change, if I'm not mistaken, to that. There's an LVEDP. And I personally support that, because the issue now is if you take a bunch of anterior infarcts who are 2 hours out, a lot of them, their EF tomorrow will be 60%. And so it's how to predict that. Now, after reperfusion, I think you can do that best with IMR. Before reperfusion is clearly, I think that the hypothesis is an important one. And there's a lot of good work to do. The key is select the right patient population.
Let me just ask a provocative question to get back to shock for a minute. Dr. Mooney, you talked about some of the data and, you know, the cardiac arrest, out-of-hospital cardiac arrest data. Over half have to be in the throes of a myocardial infarction, right? Over half, most likely. I don't know what the data is, but it's got to be over half, maybe 60%.
Right.
So if you couple my question regarding what Naveen has beautifully done and some of the science that goes back to Rich Smalling, who's still working, by the way, on animal models for this, you know, infarct size reduction, is what if you have, we take an ECPR patient successfully and we wait for the brain. I mean, if you know someone's having an infarct, what's the first thing you do? You wait for the brain to recover. You focus on the brain with hopes that you're making the right decision, because nobody likes to take a patient to the cath lab who's ultimately going to be dead. Now, I don't know if that's actually true or not still, given the confidence of some of these, you know, early scores for neurologic recovery and so forth. But my question, Finn, is do we have maybe the equipoise, given some of the data for ECPR already that appears to be making a difference, to use the ECPR as a potential randomized point of departure where you would actually say, well, now let's unload on top of ECPR those patients that have a myocardial infarction, and you would do so at a point of equipoise where you think the neuro recovery is sufficiently high probability. Does that make sense? I mean, I'm asking the question here because, to his point, you're not going to get an answer unless you do thousands of patients for that paradigm.
That's if the endpoint is mortality. But the endpoint of the study is infarct size.
But not only that, because we are talking now of LV unloading versus afterload increasing, okay? So there is a lot of things that you throw here now that are making those very, very different.
But let's stick with that question just for a minute, because Finn, I mean, I don't know what's done in your center in terms of, you know, acute infarct comes in and goes into cardiac arrest, then comes back. So you have time, but they're in deep shock. They go potentially right into, I don't know what strategy, but the question is, would you favor unloading knowing that there's an infarct there? And then when would you reperfuse that patient? Usually the patient is taken to the cath lab as soon as possible, as soon as neurologic recovery has been ascertained, right? That's kind of the standard of care. I guess I'm getting at that question, which there's a lot of variability probably in our practice.
Absolutely. I think most of our ECPR cases recover their heart function quite well. So it seems to be probably, in most of the cases, less of a problem for these patients. We do revascularize them typically at the time of putting them on ECPR if they have a STEMI at that point. So that seems to be most, so they will typically, to some extent, unload their own LV because, you know, the heart recovers. So it seems to be not so much of a problem in the cardiac arrest population, in my opinion. I think the big question here is, should every patient with an anterior STEMI coming in, you know, 60 minutes of ischemia time, should we put a big pump into their hearts and through their old crooked arteries for all of these patients to save some myocardium? I think we need some better prediction models of who will need this, who will benefit from this. Hopefully we'll learn a lot more from these trials, but I fail to see it as an all-comer strategy.
Yeah, but that's why I'm driving the equipoise. The extreme is ECPR, but what about, I mean, I've asked Naveen this. He responds, hey, you can't do it in shock yet because well, you're going to have to support the patient first, but then the question is, how long do you support the patient before you open up the artery in someone who's in shock? I think that's a very worthwhile trial to do, because I'm not sure people know what to do, right? I mean, is 30 minutes based on his animal model data good enough to just say, wait 30 minutes? How about waiting 2 hours in the cath lab, you know?
So just one point before we continue, and I think it's important to understand that actually those patients were not so sick, as you mentioned. And in the pilot, then, I remember that some of the first patients, the blood pressure went very high.
Yeah.
And the reason, they're not shock patients, okay?
Exactly.
This is AMI, not all AMI. AMI, and where is David? I now don't see with the light, is class A, unless they are deteriorating because they're at risk. And some of those patients had actually elevated blood pressure going to the cath lab. Now you put a pump in, they may actually go to even higher blood pressure, challenging actually other elements. So I know, Mike, you want to...
Yeah, I would have loved to have seen them do a cardiogenic shock, anterior MI unloading first. My worry is that this trial might be negative and people throw the concept out and without having it fully explored. I think there is a real opportunity there that it might work in the right patient population. And Dan, I know you went through this as you were discussing trial design, but you know, the intent, it's much easier to recruit for just the regular anterior MI, right?
Absolutely.
Right.
David, last comment, and we'll go. We'll continue.
Yeah, so, Finn, you know, you pointed out that that in terms of outcomes related to infarct size, that the two quartiles have a demonstrably higher risk than those that are not. So when we look at infarct size, you know, you back to mathematics, and you're really looking at area under the curve. So you can take a moment in time, and you could accession it. And I'm going to pick on the panel a little bit, at least, you know, at least my perspective of maybe a lack of understanding. And so when we talk about unloading a ventricle, what exactly does that mean? It's interesting that we went from talking about the SCI, you know, criteria to now talking about dogs. And when we're, you know, and when we're talking about dogs,
Don't forget about the sheep.
Which is part of my heart.
The sheep from Belgium.
Yes, right. You know, that's my space. I dig that. But what I would actually say then is that in fact maybe there are themes in this unloading that are relevant that are perhaps less dangerous. So you didn't come down and say you got to put an Impella in everybody or you got to put an ECMO circuit on everybody. So if you actually said that the key is to unload the ventricle in the peri-infarct period, are there ways that are less hazardous than others? Or if you had to risk stratify the patients, if you're in the top quartile where you have a troponin of 500 walking in the door versus one that's 5, maybe you go to a less risk-adverse strategy where you could still unload, but maybe not to the extent of putting an Impella and an ECMO circuit in somebody.
Absolutely.
So last question or comment from Beacon?
Transmyocardial perfusion pressure concept as maybe a decision maker for whether to unload or not. If your MAP minus your wedge is below a certain number, which will incorporate the increased filling pressures as well as the MAP, then you go and unload.
But I guess it's not just about the filling pressures. I mean, the unloading is not just about the filling pressure. It's also about we're adding energy to the heart, right? We're doing the work for the LV so it doesn't have to use oxygen.
That's why I'm calling it transmyocardial.
That's why she's saying, I
perfusion.
mean, it's interesting. I think with some echo measures, you can actually get at that parameter. There's a colleague of ours who's trying to see if that can be measured as a means of departure for deploying Impella.
It seems to be that we can continue and continue. Finn, thank you so much, and really great.